we'll start إن شاء الله. بسم الله الرحمن الرحيم. الحمد لله رب العالمين. سبحانك ربنا هديتنا لهذا وما كنا لنهتدي لولا أن هدانا الله. الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد أشرف خلق الله أجمعين. It is my great honor and pleasure today to have Dr. Abdulrahman Mansour Al-Jaradi. He is the head of Neuro ICU in King Abdullah Medical City, Mecca. He is in 2012. He have the Saudi Board of Internal Medicine. In 2015, he is graduated from the Saudi Fellowship of Adult Critical Care. Today, he will have a fantastic lecture about the brain death. I will let my colleague Ahmed Fatin to have small hands about the brain death and introduce Dr. Abdulrahman Al-Jaradi. Okay, the floor for you, Dr. Ahmed.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good night, everybody. We have today a very informative lecture about very critical topic, brain death. As all of us know that the brain death is a clinical diagnosis and has a very important aspect on the critical care. Very important for us diagnose to know how to diagnose brain death, what is the investigation, what is the legal issue related to the brain death, how we are using the brain death definitions and apply all this information for some legal issues like the organ donation and the transplants, and very important, all intensivists and everybody who work in the ICU must know about the brain death, how to diagnose, how to evaluate, how to deliver the information to the family. All this issue, it will be discussed today by our elegant consultant, Dr. Abdulrahman Al-Jaradi. He's a critical care consultant, King Abdullah Medical City. He is a head of neuro ICU, and he's very close to the issues related to the brain death in the clinical practice. تفضل Dr. Abdulrahman, and I hope it will be a very informative and excellent lecture.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for invitation, Dr. Safa, Dr. Ahmed Fatin. It's my honor and pleasure to be here with you today talking about very important topic, brain death. Hope it will be beneficial lecture for all of you. The outline of my talk gonna be definition of brain death. We should know what is the definition of brain death, pathophysiology of brain death, common causes of brain death, and how to diagnose brain death. So, and how to manage a patient who is brain dead or with potential organ donation. Definition of brain death defined as irreversible cessation of all cerebral and brainstem functioning. Brain death is legally recognized as equivalent to cardiopulmonary death in the United States. Brain death is defined by strict set of criteria that once met, it means zero likelihood awakening from coma. So the pathophysiology of brain death start by the damage happened to the neuronal cell. The damage will lead to the tissue edema of that cells, brain cells. Tissue edema will increase the intracranial pressure, and the cranial pressure will reduce the cerebral perfusion pressure, will lead to anoxic brain injury, more damage to the cells, and it will be like a virtuous cycle of death. Common causes of brain death: traumatic brain injury, um, intracranial hemorrhage, anoxic brain injury, usually due to cardiopulmonary arrest. Um, Pulmonary meningitis and encephalitis. Um, and fulminant hepatic failure causing the cerebral edema. Sorry for technical. Then ischemic stroke with cerebral edema and herniation. We finished now the causes. Then we move to the potential mimics of brain death. There is like neuromuscular paralysis, fulminant Guillain-Barré, and botulism, hypothermia. It can mimic brain death, and intoxication. A lot of drugs can mimics the brain death. This is especially the paralytics and sedative and etc. High cervical injury and locked-in syndrome. So what is the cardinal findings of brain death? The most important things in brain death, number one, coma, no cerebral mediated response to any pain. Number two, no cranial nerve functions. So it means no papillary and corneal reflex, no oculocephalic reflex, Dole's eye cold, and no cuff reflexes, no gag when suctioning endotracheal tube. No respiratory drive, patient does not breathe over the ventilator. But if the ventilatory settings rate is high enough, it might cause respiratory alkalosis, and which is normally suppress the patient on respiratory drive. Additional findings, patient is not chemically paralyzed, so deep tendon reflexes are preserved. EEG, if attached, it should be completely suppressed, totally flat, no cerebral activity. Any cerebral activity indicates that patient is not brain death. Note that, however, EEG artifacts can easily confuse this picture. Cervical or spinal reflexes may be seen, which usually confusing. Diabetes insipidus is commonly seen, but not always. Spinal reflexes, there is a huge list of spinal reflexes and movement that mediated from the spine. The list you can see it, very huge. For example, we can watch this video. if you can see here in the video that when he gave him painful stimuli, supraorbital or supramandibular and sternal rub, he didn't move at all. When he did the flexion for his neck, the patient, he did flexion for the upper limb. Same here, another video for the spinal movement. You can see that he gave sternal pressure. So when he touched and flexed the neck, the patient moved. This kind of movements we known that as spinal movement. Spinal movement different from the cerebral mediated movement. The feature that should never seen in the spinal movement that cranial nerves should not affected by spine and it's not affected by spinal movement, and pay particular attention for the facial movement. Any facial grimacing response to the pain, usually it's not spinal, it is cerebral mediated, except for some twitching, facial twitching with, we call it myokemia, not compatible with the spinal movement. Anyhow, sorting out the spine reflexes from intentional or cerebral response to stimuli, sometimes very challenging, even with the expert examiners of brain death. So if the all elements of examination, plus the neuroimaging, plus the apnea test, consistent with the brain death CT findings, so reflexes, most likely it's a spinal, not the cerebral. When in doubt, you should do the ancillary testing. We will talk about it in this lecture, inshallah. It will give you assurance. So how to diagnose brain death? Number one, to diagnose brain death, step number one, you should have the clinical suspicion of brain death. Number two, exclude any confounders affecting your examination. Number three, step number three, dedicated neuro exam. And step number four, apnea test. Step number five, confirmatory test or ancillary test when needed. So clinical suspicion of brain death, it has two components. Number one, you should have non-catastrophic brain injury consistent with brain death for a patient with undifferentiated coma. Brain death is a diagnosis of exclusion. So only after alternative treatable process have been excluded. So you should have well-known catastrophic cause of brain injury. Brain death should only be evaluated in patient with neuroimaging, example CT brain, that demonstrate catastrophic brain injury compatible with brain death, herniation, severe brain edema, etc. Number two, clinical examination consistent with brain death. This is the step number one, suspicion of brain death. Then you move to exclude confounders. Consider the all confounders, especially hypothermia. Temperature must not, patient must not be hypothermic, and the new guideline makes the temperature above 36 centigrade using esophageal or rectal temperature. Blood pressure or hemodynamics should be stable to assess or exclude the other affecting examination points like hypotension or instability. So systolic blood pressure must be above 100 millimeter mercury, and the mean arterial pressure should be above 75. Other confounders, severe metabolic, acid-base, endocrine derangements, should be corrected. This may include ammonia more than 75 will affect your examination. Should you correct before blood urea nitrogen above 75, calcium outside the range from 7 to 11, glucose outside the range from 70 to 300, magnesium outside the range 1.5 to 4, potassium outside the range 3 to 6, and sodium outside the range 130 to 160, and pH outside the range 7.3 to 7.5, and also total T4 outside the range 3 to 30, or free FT4 outside the range 0.4 to 5. So also you need to exclude chemical paralysis, must be excluded. If there is any possibility of clinical paralysis, this is must be excluded by using train of 4 nerve stimulator demonstrating 4 twitches or the presence of deep tendon reflexes. Sedating medication should be stopped and 5 half-lives should be allowed to pass prior to the brain death evaluation. For patients may undergoing brain death evaluation, it is optimal to avoid any sedating medication that do not wear off rapidly. So it is preferred to use like a propofol, Precedex on neuro ICU patients and in any catastrophic brain injury patients to have easy wear off rapidly for those medication. Systemic anticholinergic medication like atropine, it might interfere with pupillary examination and drug intoxication. Okay. Recent cardiac arrest or rewarming from hypothermia, it generally recommend that you wait 24 hours at least after the cardiac arrest or after rewarming the patient to the from less than 36. Uncommon confounders, any pathology, acute or chronic, interfere with an ability to perform an adequate neurological examination. For example, severe neuromuscular disorder, fulminant Guillain-Barré syndrome, ILC cervical spine injury, or fracture of the skull of base, petrous temporal bone may damage cranial nerve. Eye pathology or eye surgeries, traumas, surgical pupils, orbital edema, it might interfere with eye movement examination. Note the absence of 4 limbs does not necessarily prevent performing an adequate examination. Then move to the most important part of the lecture, dedicated neuro exam for brain death. Number 1, you should have coma. There should be no evidence of arousal or awareness to maximal external stimulation, including nauseous visual stimuli, maybe assessed while examining the pupil by light, or pain in any extremity. It should be absence. There is no awareness, no arousal. Pain in cerebral orbital notch and temporomandibular joints bilaterally. Deep sternal rub. There should no vertical eye movement to stimulation or command, as this could be occur due to locked-in syndrome. Spinal reflexes may occur. So testing the motor response to painful stimuli. Here, the picture showing the supraorbital applying of the pain, pressure. So move to the next examination, pupillary reflexes. There should no pupillary any movement or reflexes. So absence of ipsilateral contralateral papillary response. In brain death, pupils are generally fixed mid-position or fixed dilated. Notice, please, that very small pupil, less than 2 millimeter, are usually not seen in brain death. And instead, this may suggest the possibility of drug intoxication, locked-in syndrome. They call it pontine pupils. So you apply the testing, the pupillary response to the light like this. And the dedicated neuro exam, move to the corneal reflex. Corneal reflex touch the lateral aspect of the cornea of both eyes with cotton swab. Enough pressure should be used to slightly depress the eye. Common mistakes here, please notice the mistakes here. Testing corneal reflexes by dropping saline into the eye. This is inadequate to establish brain death, since it does not provide the strongest stimulation to this reflex. Applying the stimulation to the sclera rather than the cornea. So you will apply here the cotton to the sclera, the cornea, not the sclera. And here the picture showing what is the cornea, and you should apply from here to here. This space is yours. Apply in the cornea. Don't apply in the sclera. Move to the next exam, oculocephalic and oculovestibular reflexes. Any extraocular movement is incompatible with brain death, so eye should not move. Oculocephalic reflexes may be skipped in patient who has unstable cervical, and oculovestibular will be covering this examination part. Oculovestibular reflexes, what you will do, you will irrigate at least 30, but in our protocol, Saudi Center of Organ Transplant, 50 ml iced water in adult, at least 60 seconds, allow 5 minutes in between testing different side. So this is the oculocephalic examination. You will open both eyes, move the head of the patients to the right and to the left. Dull eyes, it should have no extraocular movement. So the all dulls, if you know them, the eye, if you move the head, it will move same movement to the head, not the normal movement. If we move our head, the eyes will go to the other side, as here in the picture. So this is the caloric test, which we mentioned before, that you will inject 50 ml iced water to the ear. Make sure that patient have intact tympanic membrane. Move to then cuff and gag reflexes, very important. Should have no gag reflex. Ideally tested by suctioning the back of the throat, patient throat with Youngker's catheter, including a stimulation of both sides of the posterior pharynx. No cuff reflexes tested by inline suction of the endotracheal. So with suctioning endotracheal also, there will be no cuff and no gag with the suctioning by Youngker. Here the picture showing the examination of the gag reflexes, and we explain the cuff reflexes. Electroencephalography or EEG, if attached, it should be flat EEG, and it was component of brain death examination before, and with the last update of the brain death protocol 2023, they remove it from the guideline. Anyhow, some countries is still using. We are still using the EEG. It should be flat EEG for 30 minutes. And should be read by an expert for that. This is the guideline. Everyone is recommended to review them. It includes all aspects and conflicts or steps of brain death examination. So in that, they remove a statement 28, clinician should not use EEGs, any evoked potential examination as ancillary test for brain death or death neurocriteria. After you finish the examination, you will do the apnea test. Later, we'll show you the protocol of the Saudi protocol of brain death examination form and the steps, inshallah, in this lecture. So apnea test meet prerequisites. Patient must be stable enough to tolerate apnea test, because if patient already severely hypoxic, acidotic, he will not tolerate the apnea test. Ideally, PO2 on 100 oxygen percent more than 200. So he's not in RDS, for example. PCO2 should be normal, or if patient non-baseline, he should be in his baseline of COPD or hypoventilation syndrome. If the patient has evidence of chronic CO2 retention without knowing the baseline, the apnea test should still done, but an ancillary test also should be performed. Absence of other confounders, same as brain death, should be absent, all the confounders, and core temperature more than 36 again. Systolic blood pressure above 100, MAB above 75. Prior to the test, you will prepare your patient by pre-oxygenation with 100% FiO2 more than 10 minutes. Obtain baseline ABG. PCO2 should be normal in the range from 35 to 45 before starting the apnea test. If still you are outside those range, you adjust your ventilator and document normal EVG with normal PCO2 prior to examination. Guideline suggests that functioning arterial line should be used because you will need continuous blood pressure monitoring and quickly drawing the blood gases during the apnea test. Consider vasopressors initiation if blood pressure borderline. One of the most common complication of the apnea is hypotension, and so preemptively start pressors, target maybe higher MAB 85 to avoid aborting the test, that it will take time to prepare again to do it. If there is any respiratory effort, so you start the examination. If there is any respiratory effort, then patient is not brain dead. Reconnect ventilator immediately and resume the supportive care. Consider repeating the apnea test after 24 hours if still clinical examination consistent with brain death. The patient is disconnected from ventilator. The oxygen usually provided by tracheal cannula at 6 liters per minute, and the tip of the should lie at the carina. There is alternative using TBs with oxygen flow 12 liters per minute, or using CPAP 10 to 20 centimeter water with oxygen flow 12 liters per minute. The usual type we are using the tracheal cannula oxygen 6 liters. So when to abort the examination, the apnea test, if patient became unstable, for example, hypotension, systolic less than 100 or MAB less than 75, despite titration the pressors, sustained desaturation less than 85 for more than 30 seconds, unstable arrhythmia happened, NABG should still be obtained at the time of the apnea termination If the BCO2 high enough, then the test may be still adequate and establish lack of respiratory drive. So continue the apnea test for 10 minutes. If the patient can tolerate this, then check the arterial blood gas. If point of care ABG machine available and the patient unstable, then the apnea test may be continued while awaiting for the result. It will take few minutes. Then if ABG does not sufficiently hypercapnia, or the ABG may repeat it frequently with ongoing apnea test, you can extend the apnea test if more than 10 minutes if the patient is stable. If unfortunately some units, they will not have point of care testing available. So then draw the ABG after 10 minutes, reconnect the patient and see the ABG if met the criteria we will mention now. In order to conclude that apnea test is positive, the patient has no respiratory drive, following targets should be required. pH should be less than 7.30. PCO2 should be above 60. For patients with pre-existing hypercapnia, it should be above 20 from their baseline and should have no respiration occurs at all. 10 minutes apnea should be sufficient to meet this criteria most of the time. But if PCO2 does not increase sufficiently, the entire test may be repeated with the same steps as we mentioned before: pre-oxygenation, baseline ABG with normal PCO2, and extend the duration for 15 minutes. Step number 5, we will move now to when we will use confirmatory test or ancillary test. We will use not in all patients. In some situations where a confirmatory test is needed. Number 1, if there is a presence of any confounding factors, as mentioned before, this include any metabolic derangements that cannot be adequately corrected, inability to perform apnea tests. For example, patient is severely or too hypoxic to tolerate the apnea. Uncertainty about movement, whether are spinally mediated reflexes or not. Some countries require confirmatory tests by the law, but it's not in the United States. So what the confirmatory test we can use? Most useful confirmatory test, cerebral scintigraphy, and it should be showing the empty skull. So what they will give radio-labeled dye is injected in the peripheral vein. If there is perfusion to the brain, the dye will be taken up to the brain tissue. If brain death, lack of brain perfusion causes empty skull sign. And cerebral scintigraphy, which shows lack of blood flow to the brain, based on the official interpretation by an attending radiologist, is extremely solid evidence of brain death. Sometimes early process of brain death, there may be a small amount of perfusion remaining. In this case, a repeat test may show lack of flow. Unfortunately, delay may be required to repeat the test to allow reduced tracer for washout. So here, very important point, if blood flow is fully preserved, this is suggests the possibility of brain death mimics. As we mentioned before, intoxication, locked-in syndrome, the underlying diagnosis should be considered and found. Transcranial Doppler can be used as confirmatory test. A single Doppler showing absence of flow is not reliable. It should be a sequence of transcranial Doppler results showing progressive reduction of blood flow, may be strongly supportive in brain death. If available, cerebral scintigraphy is preferred over the transcranial ultrasound Doppler because is this operator dependent, allowing high quality of scintigraphy study that interpreted by radiologists to be near يعني not compatible completely with the brain death. Also, one of the gold standards for Fes's catheter can be used, and one of the recommendation even in the guidelines. All those three tests, one of them is enough. So approach here, we mentioned it before, and the so what is the immediate steps of brain death? If brain death confirmed, number one, you will determine the time of death. Time of death is the time of apnea test, or if you require to do ancillary test, is the time of the ancillary study documentation. The family should be informed that patient has died with the appropriate explanation of the brain death. Do not discuss organ donation with family. This should be done by a separate team responsible for organ transplant. This is the forms of brain death. It is 2 pages. I will zoom it now. So this is the page number 1, first exam. It should have the precondition. You should document here. You should document that the cause of brain death here. So you before continuing the examination, you should document the cause: intracerebral hemorrhage, for example, anexic brain damage, etc. More than 6 hours passed since the insult happened. Coma without any spontaneous breathing. Then this exclusions temperature should be above 34, and sedation are stopped, and he is not in cardiovascular shocked, and there is no endocrine or metabolic cause of this coma. Then, if that's done, you move to the examination. As we mentioned before, here, lack of response for the painful stimuli, you will not see any movement. Absence of brainstem reflexes, pupil to light should be absent, corneal reflex absent, oculocephalic absent, oculovestibular absent, gag and cuff absent. Here, consultant number A, consultant B should sign on all steps or write their findings. Then they will sign. After that, you will move to confirmatory tests. Here, we are using EEG or one of the ancillary tests before going to the next exam. So usually we will do EEG and it should be flat here. Then same, we'll move to page number 2. Page number 2, it contains same examination without EEG. It should contain apnea test. So it ends by apnea test. Then temperature here for apnea test in Saudi protocol should be above 36.5. Then if apnea test positive, so that means patient is brain dead. This is our form in our hospital. Okay. Then if you announce that patient is brain dead, you should manage him for if he is candidate for potential organ donation, which so general resuscitative principles that any patient potential donor are should be stated similarly as any patient in the critical care. So with high quality of supportive care, breathers if needed, antibiotics, all supportive care needed should be given to the potential organ donor. We'll add corticosteroid. Reason to give steroid because brain death can cause pituitary deficiency. It will promoting hemodynamics instability. Steroid may reduce the inflammation, thereby improving graft function, organ functionality. Usually it is large dose, 1,000 milligram or 1 gram methylprednisolone daily. Most of the patients, they will develop diabetes insipidus, commonly occurs, but not always. If it happened in context of brain death, diabetes insipidus may be strongly suspected. So you will see copious diluted urine, high urine output, production. Differential diagnosis may include hyperglycemia, hypothermia, or diuresis medications. Or if in doubt, you send for urine osmolality. Urine serum sodium should be high. Urine osmolality should less than 200, and urine specific gravity less than 1.005. However, the treatment should not be delayed while waiting for the result to return. Treatment is simple. There is 2 options. Number 1, desmopressin. Desmopressin usually IV or subcutaneous, 2 to 4 microgram Q6 to 8 hourly. Advantage, it's easy to do, does not tie up an intravenous line, no need for central line. Disadvantage, if hyponatremia occurs, the desmopressin will take hours to wear off. The other option, that vasopressin infusion, but not the usual dose, very low dose of vasopressin are sufficient to reverse diabetes insipidus. Usually the dose from 0.01 unit per or lower. This does not won't necessarily have much effect of hemodynamics. Also, if patient is already hypotensive, we can use the hypotensive dose, higher dose as generally given, 0.04 units per minute. Advantage, it is titrable, and so you can turn it off if hyponatremia or low urine output occurs. May help to support blood pressure if hypotension. Preservation of the lung function, avoid subclavian line insertion because it might cause pneumothorax, won't have time to heal, potentially making the more problematic. Bronchoscope if is required to evaluate candidacy for lung donation. Avoid performing bronchoalveolar lavage if possible. If mandatory, use lowest volume of saline possible. Avoid volume overload. If cardiac function affected, you treat like any patient with low or cardiogenic shock or stomach myocardial systolic heart failure. So with any like any supportive care, it usually improve over the time, similar to any cardiogenic shock. Thyroid hormone supplementation may be assist in cardiac recovery. So following brain death, usually sick euthyroid state frequently occurs. So with elevated level of inactive reverse T3, low levels of inactive T3 and normal T4. So you will use exogenous thyroid hormone has commonly been used in effort to improve cardiac function and candidacy for heart donation. No high level of evidence to support this practice, but still controversial. So consider to use it. if hemodynamic instability and the patient ejection fraction less than 45. Usually the dose you will discuss with your pharmacist, and the thyroxine if using 20 bolus, then 10 microgram per hour. If you use T3, 4 microgram bolus followed by 3 microgram per hour. Temperature, usually the patient, they develop spontaneous hypothermia. You should monitor and externally rewarm your patient to avoid hypothermia. Empiric antibiotics usually needed, so administer broad spectrum antibiotic needs for your patient. Control blood sugar, glycemic control should be maintained with insulin infusion most of the time. Typically, blood sugar should be from 180 to 240 milligram per deciliter. Here, this is maybe 2 years ago, one of the cases from King Abdullah Medical City that one patient donate and save 5 patients. As you can see, maybe 2 years ago. And here, the transplant center in Saudi Arabia, the number of the people they want to donate their organ, number of the people waiting for donors, almost 2,000. This is maybe old statistics 1 year ago I collect. And number of donors that donate, number of the operation, 21,586. One organ, one donor can maybe donate for 8 patients, heart, lung, liver, pancreas, then kidneys and bones, corneals, heart valves. ومن أحياها كأنما أحيا الناس جميعا. Here, before ending the lecture, listen to the Islamic scholar Sheikh Abdullah Mutlaq about the fatwa.
Dr. Abdul Rahman, please, no voice for the video, please.
No voice?
Yeah.
أن يتبرع
No.
Yes.
أولياء المتوفى دماغيا بتمكن من أخذ أعضائه التي يستفاد منها وإعطائها إلى من هم في حاجة ماسة إليها، وحينئذ يؤجر المتوفى لأنها أعضاءه، ويؤجر وليه الذي تبرع بها، ويسجل ذلك لهم من الصدقات الجارية.
With that, I
أن يتبرع
conclude my lecture, and thank you, and ready for any comments or question. Thank you.
Thank you so much, Dr. Abdul Rahman. Very comprehensive lecture. Thank you. Thank you. It was the first time for you to share with us, and of course, will not be the last one. We will, all of the time, will be honored to have you, Dr. Abdul Rahman. Thank you so much.
Same here, same.
Dr. Ahmed.
شكرا دكتور عبد الرحمن. Thank you so much for this informative lecture, and يعني you are touching the very important topic in our daily ICU practice, the brain death, how to diagnose, how what about the workup for the brain dead patients, But the question now, Dr. Abdurrahman, because we are facing a lot of legal issues, when we can deliver the brain death to the family, and to whom in the family, يعني يعني to the most responsible one in the family, or to يعني how can to speak to the family about that your patient is brain dead, and also what about the de-escalation of ICU care? يعني can we discuss this about the vasopressors? We can wean the vasopressors, or we can يعني I know in our Islamic countries the de-escalation of the care is not allowed, but if the family ask to de-escalate or to withdraw the ICU supportive care.
Okay, thank you, Dr. Ahmed, for these questions. The answer, number one, the family should understand the situation of their loved one before starting the brain death examination. The recommendation is stating that brain death examination does not need a consent from family. So usually any hospital or institution, they will have admission consent. It should include everything, patient examination, patient management. So you will examine the patient, then in the beginning, usually you will deliver that they have catastrophic brain death, catastrophic brain injury. This is a message should be given in steps, not a one the breaking bad news is a skill, maybe another lecture by another expert. So you should deliver step by step the bad news. And then usually if you deliver the first degree of relative, not any friend or second degree relative, should be to the first degree relative, for example, the husband, father, etc., brother, first degree. And usually the aim to confirm the doctor job, the intensive job is to confirm that patient is not brain dead. So you are doing all those efforts, all those examination steps to confirm that he is not brain dead. You want to confirm that he is alive. But if examination confirm that he is brain dead, the next step is to inform the family and inform the transplant center in your country to start the process for donation or organ transplant. And you are, as intensivist, continue to support the patient till the decision of donation will come to you. Either they agree for transplant, so patient will be taken to OR and his or her organ will be taken, or reject the transplant or donation subject, so patient will be DNR most of the time. I hope that I answered.
May I understand something from Ahmed. What will happen if you confirm brain death, Dr. Abdulrahman, and you tell the family that your beloved one has passed away, and they insist that you should complete his resuscitation and go in the same pathway to be conservative or such issue. What will you do in this situation?
Yeah, usually we will do a family meeting. Before that, as I mentioned, we should inform them about the brain injury.
Yeah.
Number one, inform them about the situation that it is critical, and we will going to do something called brain death examination or confirmation.
Yes.
This is before anything. Okay. Then I will do the brain death examination. The brain death examination, if confirmed the brain death, we will do official family meeting with the first degree relative. We'll inform them in simple language what is the brain death, simple, summarized language. What is brain death? What we did. And in the recommendation, by the way, the guidelines, they ask if you, but maybe it's some countries difficult, they can attend the brain death examination and even apnea test. But here are some countries it's very difficult. So inform them in simple language that their beloved one is considered brain dead, which is equal to cardiopulmonary death. Then you should continue to support the patient for a period. Let them absorb this bad news. Then the Center of Organ Transplant will communicate with them, and they will have their discussion, agreement or rejection. Then after that, you will decide to, if acceptance came for donation, okay, alhamdulillah. If not, rejection will still, we will continue to support for a period, maybe 1 or 2 days. Then he should be DNR most of the time.
Okay, great.
Thank
For
you,
me,
Dr. Abdulrahman. I am asking Dr. Abdulrahman in our practice regarding the spinal reflexes. You focused in your lecture about the spinal reflexes. The patient is moving. How can we explain to the family that the patient is clinically dead or that he is brain dead? But he will definitely he will reply that the patient is moving. How can we inform them or convince them in very simple way by the language they can understand, avoiding medical terms that this movement is useless or it's not reflecting that the patient is alive or not compatible with the life. How can we explain that regarding the spinal reflexes? Especially in our communities, the culture is very different. They will tell you that how the brain is dead and the patient is warm, the patient is moving. How can we convince them, especially in our communities?
Yes.
Okay. In the recommendation, they state this. You will explain if the family attend the brain death examination, you will explain the steps of brain death examination that you will do, and you will tell them spinal reflexes might happen during examination, which is not also consistent with the cerebellar mediated movement. So you will explain that this is steps what I'm doing. If he didn't do any reflexes, brainstem reflexes, painful stimuli reflexes, he is not breathing. So those steps, we call it cerebellary mediated reflexes. If spinal reflexes happened and you are in the situation need to assure the family or you assure yourself, you can move to the ancillary test. We mentioned it before. 3 tests you can do for Fissel's angiogram. Number 1, number 2, transcranial Doppler, or nuclear study. This will confirm the brain death for them.
Yes. Just a comment, Dr. Abdulrahman, that if the injury is above C4, so this peripheral reflexes may occur from C4 then downward. For example, the diaphragm intraoperatively during the process of organ donation or the lamp like you show may occur. But it is temporary for time and will disappear, these spinal reflexes. So spinal reflexes may be also a ghost for the anesthesiologist who is carrying the brain dead patient going for organ donation. It's a ghost also, Dr. Abdulrahman, for us.
Yes. Yes, any movement
Any
will,
movement, yeah,
yeah,
not for the family
will,
only. It's also for us. Or it may be unclear for us, or something hidden, or something going wrong. What will happen? What we will behave in such a situation?
yes,
Very difficult one.
totally agree.
Yeah, Dr. Abdulrahman. Of course, in our countries, as you know, and we have warm feeling toward our beloved persons. And there is many bias and controversy about the organ donation. After fatwa of Dr. Al-Mutlaq, it is very clear for me, very clear for all the highly educated personnel, but still for the people, popular orientation, that all the organ of poor people will diagnosed wrongly as a brain dead, and their organ will go to the rich one. This is bias in our communities.
Mm.
Believe me, they think of that. And still now, even after Dr. Al-Sha'lan, the head of organ in Saudi Arabia, tell us in one conference in Egypt that after documentation of fatwa, Kubar al-Ulama in Saudi Arabia, we should say nothing about fatwa again. There is one since 10 years and more. Why we are go back?
Yes,
So how to eliminate this bias, this controversy from our community?
it's still difficult. Education, it will play a role. Now also there is something here. You can, as a live person, register yourself as a donor in Saudi Arabia. If
Yeah.
something happened to you, you can register that you want to donate your organs if something happened to you. So in the Kalna application, you can register yourself, as we see in the registration, a lot of maybe more than 500,000 registered that they want to donate if something happened to them and they became brain dead. So the education media should play role more than health worker, because we are busy with our work. The media should play a role
Yes,
here.
yes. And we can show the success story of organ donation and how we have a young man under mechanical ventilation for many times, and he is now transplanted and he's alive. So we give life to another one.
Yes, sure. So you give
Donation
lives to multiple
stories.
people.
Yes,
Yes.
yes, yes. Also, I have a comment because I'm interested in brain dead. Yeah.
Oh, thank you.
I'm sorry, Dr. Abdulrahman. I also know that artificial intelligence have a great role in determining the diagnosing the brain death, and even the chat GPT and the communication may enhance the communication in many centers that waiting, if we have many waiting person for donation via ChatGPT, they can communicate with another centers if they have brain death now, and we can transport the organs like that. Is it right? Is this really okay?
In the guideline, still no, not mentioned that the practice of the way, and nothing to replace a trained physician to diagnose the brain death. And even the guideline, they emphasize that the intensivist and neurologist and neurosurgery surgeon that should receive a training, specific training for brain death, online or inside courses. So no machine should not diagnose brain death, or computers and chat GPTs. Diagnosis should come from trained physician, certified to do this.
No, I don't mean that they will replace the consultant will confirm. No. Just they send a message that, for example, the center of King Abdullah now has brain death patient, and in Cairo, for example, or in Bahrain or in Qatar, there is one who is waiting for transplant. So via community ChatGPT, they will know the waiting list here and the brain dead patient here, and will communicate and may enhance the process of donation.
Usually our rule to confirm brain death, then the donor transplant rule is usually taken by another center or institution. Our rule is only to confirm, then inform that we have potential organ donor. The center for transplant, he will approach the family. If they accept, then according to the patient blood group and things, they can found for him the people to donor to them.
Dr. Abdurrahman, it's Dr. Mustafa, very important, the home message. As intensivists, we are not allowed to discuss with the family about the organ donation. It's very important, just our rule to diagnose, to confirm, but never to open the discussion regarding the organ. This is for the medical legality, for the medical legal issues. Not allowed. I am talking about our protocol here in Saudi Arabia. Not allowed as intensivists to discuss with the family or to open the discussion. Never about the organ. There is independent centers and the independent way. Another way. They are. Just we inform them there is a brain death. They are responsible to discuss the organ donation with the family, because it's not easy to now we will inform him that the patient is brain dead, and we will take the organs now, and he is ready for the this is still for medical legal issues. We are not allowed to open the organ donation issues with the family.
Yes. Of course, the time between Dr. Abdurrahman, you confirmed that Mr. X is now brain dead, and the other team or the other center and the family are agreed that this patient consenting for organ donation. The role of anesthesiologist to keep this patient with brain death till being validated to organ donation or transported to the center of organ donation, it is one of the critical role of anesthesiologist. I suppose that. How to keep blood pressure? How would you transport the patient to OR? How to keep the hemodynamics of the patient, the temperature, the endocrinal function, as you mentioned, if there is any complication as diabetes insipidus, as you mentioned, and the method of anesthesia, which type of muscle relaxant we will use. You will use IV anesthetics or inhalation anesthetic. This is very critical rule for the anesthesiologist to receive the brain dead patient to transport them to OR where the organ donation will be done. Yes, thank you. Thank you so much.
Thank you.
Anyone have a question from the floor, please? It was really a fascinating lecture. Thank you, Dr. Abdurrahman.
Thank you.
Jazakumullahu khairan. Dr. Ahmed, have you any question or one of the floor?
No, but just someone is asking if this lecture is recorded. Yes, it's recorded, and it will be published, inshallah, in the Egyptian Society of the Anesthesiology and Acute Care. It will in our channel, the YouTube. It will be uploaded. Thank you, Dr. Abdurrahman, for your lecture. It's very informative.
Thank you for invitation.
Very amazing, really. جزاك الله خير
جزاكم الله
ونفع
خير.
بك دائما. Thank you for our
آمين.
colleague,
أجمعين.
all attendees. And
Thank
إن شاء
you.
الله نلتقي في لقاءات علمية أخرى. Thank
إن
you
شاء
دكتور
إن شاء
صفاء.
الله.
Thank you
Thank you.
Ahmed. Thank you. Thank you Dr.
شكرا.
Abdurrahman, and waiting
جزاكم
for
الله خير.
really sharing إن شاء
إن
الله.
شاء الله. إن
إن
شاء
شاء
الله.
الله.
Thank
Thank
you.
you so
في أمان
much.
الله.
جزاكم
مع
الله
السلامة.
خيرا. السلام
في أمان
عليكم.
الله.
السلام عليكم.
وعليكم السلام
السلام
ورحمة الله وبركاته.
عليكم.